And we move on to the, without much ado, to the next session, which is a final session for the day, which deals more with surgery and other medical and physiotherapy for back and spine related problems. For this session, I would like to invite Dr. Amol Rege, Dr. Pragnesh Shah, and Dr. Ramesh Bansode to chair the session. Dr. Amol, yours.
Thanks, Gautam. So this is the last session. It will be a very interesting session, looking after new technologies and certain concepts that you get paralysis. Can you hear me?
Yes, we can hear you.
So certain myths about paralysis after spine surgery, all those will be clarified in this session. So I invite the first speaker, Dr. Nitin Jaiswal, who is going to tell us about exercises. And he's a famous spine surgeon from Mumbai. Dr. Jaiswal, all yours.
Good morning. Myself, Dr. Nitin Jaiswal. I'm a consultant spine surgeon. And today I'm going to discuss the topic exercises, the key to successful resolution of spinal complaints. What are the causes of back and neck pain? Most common, poor posture, lack of exercises, muscle strain and sprain. Other causes are spondylosis, that is wear and tear of the disc and the joints, sciatica, that is leg pain, stenosis, that is nerve tightness, and domestic falls. There are three different important factors which are responsible for spinal pain, which includes biological, psychological, and social. Biological factors includes a primary pathology in the spine, like facetal arthropathy or degeneration. Psychological includes anxiety or depression. And the third factor is social, in which a lack of social support or low socioeconomic status. We must identify the primary factor responsible for spinal pain and we have to treat the patient accordingly. Why do back and neck problems become chronic? Whenever a patient is having back or neck pain, he or she will take a bed rest or will avoid normal activities, which will result in muscle weakness and joint stiffness, which will lead to loss of confidence, and ultimately the patient will become either anxious or depressed, which will result in back and neck pain. This is a vicious cycle, and we must target to break this vicious cycle. Our philosophy of rehabilitation is to break this vicious cycle by allowing activities within pain limits. We must ensure that patient should do activities within limits of pain. Bed rest is bad for back. Exercises should be within pain limits and gradually progress to strengthening exercises. We must reassure the patient. We must educate them for physical conditioning. They may need help to deal with their emotions and for self-motivation. If needed, professional help should be provided. What are the goals of rehabilitations? The first goal is acute pain relief by releasing contracted tissue and mobilizing the joints, which will result in decreasing the stiffness. A second goal is preventing recurrence by improving muscle strength and improving endurance. And the last goal is to help them to return to activity by improving neuromuscular coordination and promoting confidence of well-being. There are different types of exercises. The first one is endurance exercise, which are aerobic exercises, which help us to increase heart rate and respiratory rate and improves heart and lung function. Our second exercises are strengthening exercises, which makes a day-to-day activity easier and prevent falls and falls related complication. Third group is a balance exercise, which help us to prevent falls and its complication. And third is flexibility, that is to increase the flexibility of the joints. In our protocol, we have formed a rehabilitation pyramid in which the base is formed by range of motion exercises, stretching and strengthening exercises for the joints, and postural rehabilitation for pain relief. Strengthening exercises to prevent recurrence. And third layer is formed by aerobic exercises, which is for improving the functions of the heart and lung. And the top layer is formed by recreational sports. This is one of the paper from Korea, which shows that atrophy of the psoas major paper, which shows that lack of muscle strength itself can lead to back pain, even in absence of degeneration. These two papers suggest that strengthening of low back muscles or back muscles can improve a back pain. Now the question is, what exercises? What type of exercises? There are different types of exercises. Flexion program, extension program, yoga exercises. And we don't know whom to put on flexion, whom to put on extension, or whom to put on different programs. The key thing is the exercises should be according to individual patient's needs, and key to success is activity in any form rather than any specific exercises. For that, we must examine the patient in detail, and we must see what what are the movements which are possible or painless for the patient, and we must prescribe the exercise program accordingly. Core includes all the muscles of the body besides arm and legs. The core support the spine, pelvic girdle, and rib cage. And core is involved in almost every movement of the human body. So our target should be to strengthen the core muscles, which will stabilize the spine and help us to reduce the pain. These are the few exercises which are included in extension program. As I told you that a patient with disc pathology will have free extension as compared to flexion. So this patient should be put on extension program. Extension exercises will strengthen the extensors of the back and help us to reduce the pain. This is the flexion program, which includes core strengthening exercises for the abdominal muscles. A patient with lumbar canal stenosis or listhesis will have free flexion as compared to extension. So this type of patients can be put on flexion program. These are the neck and shoulder muscle exercises. Upper row includes a simple neck exercises, and second and third includes exercises with resistance. Initially, a simple exercises can be prescribed, and slowly and gradually they can put on the resistance or strengthening exercises. This slide shows upper or mid back exercises. The patient with dorsal back pain can be easily put on rotation exercises, as most of the rotation occurs at dorsal spine. Finally, before concluding, I would like to stress on this paper from Australia. It suggests that an exercise approach based on identification of patient-specific tailored intervention has potential to dramatically improve outcomes, which means the exercises should be individualized according to patient, and not we can't put all the beans in a single bag. Finally, to conclude, a low back exercise are most beneficial if performed daily. Frequency of exercise is more important than duration. Exercises should be allowed within pain limits. Inclusion of general exercises, that is aerobic, is most effective. Emphasis should be endurance over strength for low back health. Training objectives must be identified individually, and it may take 3 months to observe improved function and pain reduction. Thank you.
Thank you, Dr. Jaiswal. Can I request Dr. Bansode to invite our next speaker? Can you unmute yourself, Dr. Bansode? Can you unmute Dr. Bansode?
Yes, good day to everybody. We are
Yeah, now
already
clear.
2 decades in 21st century. The spine surgeries are not only minimally invasive, but they are with minimal or no complications at all. That is the message to the patients also what I give them. Our next speaker is going to talk about the same topic, the spinal surgeries and myths. There are no complications. Let him continue.
Morning, everybody. At the outset, I'd like to thank the organizers for asking me to speak on the myths of spine surgery. Now, this is a picture from the internet which quotes the 7 myths of spine surgery, starting with I'm going to be paralyzed until surgery is done immediately, which is entirely false. Most of the spine surgeries give you a lot of time to decide, especially the elective ones. I have bulging in my discs in the neck or back and need fusion surgery. This is also usually not done until and unless the neurological structures are trapped or impinged. Myth number 3, I'll never be able to get back to doing things that I love, which is again absolutely a myth because spine surgery is done to let you get back to your original life module so that you can get back to work, get back to your leisure activities. And if you cannot do these things, then there's no point for spine surgery. Myth number 4, I'm too old for spine surgery or that I'm too young. Spine surgery doesn't have a particular age protocol. Maybe that one type of spine surgery is not suitable for the kid, or an extensive spine procedure might be too much for a very old, frail pediatric person. But spine surgery is done at the extremes of age also. Nobody is too young or too old for spine surgery. And number 5 and number 6 is it is never successful. It is my only option. We know that in our current treatment modalities, there are many sort of non-surgical treatments also available. And the fact that spine surgery is never successful is an absolute blatant myth because the success rate of spine surgery in most of the centers in the world are over 9%. Finally, the one which I'm going to speak to you upon in a little bit of more details is that I'll be disabled and paralyzed from spine surgery, which leads to my topic of paralysis of the spine surgery, a myth. Now, again, thanking the organizers, I'd like to put forward the important fact that the most important anatomical issue regarding spine is that it is unique because it has intrinsic structural and functional properties. The musculoskeletal part is responsible for giving the structure or movement or resilience that gives the trunk the particular shape, and the neurogenic part, which is encased by the bone and the ligaments and the muscles and the joints, they are actually the important information traversing system. That means the information from the brain is relayed across by these nerves to do the most important functions of the body. And spinal disorders range from degenerative, traumatic, infective, neoplastic, inflammatory, congenital to importantly spinal deformities. And we all know that there are 3 regions of the spine. Now, out of which degenerative lumbosacral region is the most important, most frequent cause of spine surgery. And as I'll tell you shortly, it cannot cause paralysis. If you look at degenerative disc disease, you have to understand what is a normal disc. A normal disc is a sort of a sandwich layer between 2 bones, and when we have a weight across it, there is a very even distribution of weight which leads rise to movement. And a degenerative disc, there is an abnormal distribution of load, abnormal movement, and this is what gives rise to pain. And if you look at a particular patient of back pain due to disc, it might be due to disc degradation or a resorption or internal disruption when there's a tear of the annulus fibrosus, and usually it leads to back pain. For example, this L5S1 dark disc is a degenerative disc which internal disc disruption, and this gives rise to back pain alone. Whereas a patient with a prolapsed intervertebral disc would give rise to leg pain, which might usually go beyond the knees, and this is what surgery is mainly for. Now, when we are doing at spinal surgery at L4-5 or L5S1, which is the commonest levels, we must realize that the spinal cord ends at L1, which is the conus medullaris. Below that are the roots, and the exiting roots are usually far below, far lateral to the conus, and obviously surgery on that part of the spine cannot give you paralysis. Most lumbar surgeries at 4, 5, and 5, 1, and even the screws and rods, they are placed far away from the rods, from the nerves, and they cannot injure that. Hence, there cannot be any chance of paralysis after a lower lumbar surgery. A prolapsed lumbar disc is the commonest disorder, and we know that either the L5 root or the L4 root can be affected for L4-5 disc prolapse, and typically presents with radiating leg pain, and microlumbar discectomy is the procedure of choice. It is that smaller incision, it's about an inch or 1.5 inch incision, with that smaller an amount of ligament which is resected, hardly any bone, and obviously can never give rise to paralysis. Similarly, a patient of spondylolisthesis, as you can see, L5 is far ahead, falling forwards on S1, leading to a positive cervical imbalance. It's only by a single level rod screw we could reduce it. And the fact that after fusion, you see this patient who is that much bent, again stands up straight, and there is a much harmonious normal lumbar lordosis and thoracic curvature which happens after surgery, and all this by single level surgery. This is a preoperative and a postoperative standing film to show you how much of correction we could achieve by just putting in 4 screws, 2 rods in a cage. And before going on to spinal surgery, we must realize that these are very, very safe provided you are doing it regularly, and most of the spine centers in the country are doing voluminous amount of spine surgery. Now, going from the lumbar spine to the cervical spine, the anterior cervical discectomy and fusion is a very common surgery, and there are a lot of myths regarding whether this causes paralysis, whether I will be able to walk, I'll be able to use my hands ever or not, and whether I'll be able to uh, have a normal voiding pattern so far as uterine and stool are concerned. Paralysis or major disability now is no more a frequent problem. This is the improved technology, and the most important equipment which has actually changed the entire gamut of these surgeries is the microscope. Not only giving rise to enhanced illumination and a better magnification, you can turn it around, rock it around, and easy vision in the nooks and corners of the anatomy are extremely important and very beautifully visible in the microscope, making these surgeries and cervical discectomy fusion very, very successful. And this is brought out the statement is a myth that paralysis occurs after cervical spine surgery. But these patients who are bent forwards, who are deformed, this is a patient with ankylosing spondylitis, they hardly can look forwards. The spinal deformity correction surgeries, they are very major surgeries, and they are potentially risky surgeries for paralysis. Now, if you ask me what is the rate of paralysis, in a scoliosis surgery in adolescent idiopathy, it is less than 0.1%. In a congenital scoliosis, it might be about 2%, whereas in ankylosing spondylitis, it might be hardly 2 to 3%. So not only percentage is very high, but of course, paralysis is a devastating complication. And these surgeries are extensive. They require a section of bone all around the spinal cord, as you can see, putting on multiple rods and screws and doing osteotomies. And finally, you get an extreme correction by an L3 pedicle subtraction osteotomy, and you can see the patient is standing up straight again. Now, these things were unthinkable in the past, but nowadays they are pretty routinely performed surgeries. And what has made these surgeries much, much more safer than previously? A patient who hardly can look forwards can now look up straight, gets a very good sagittal balance because of this machine, which has actually made earth-shattering advances in the care of deformity surgery, because this is a live monitoring of the neural function during the surgery. We're continuously stimulating the various motor tracts with sensory tracts of the spinal cord, and gives rise to responses which are recorded. And when we are doing the surgery, we are continuously recording the responses of the legs, so we know whether we are leaving the patient paralyzed or not. And with this machine, paralysis has really, really become a myth in deformity surgery. So to conclude, paralysis after spine surgery is really a myth. It is practically impossible in all lumbar surgeries. It is only a rare and temporary complication in cervical and thoracic surgeries, and the operating microscope has brought down the rate of complications and made it an extremely safe surgery. Finally, it is a potential complication in rigid spinal deformity correction. Intraoperative neuromonitoring is a wonderful tool for preventing and reducing paralysis after surgery. Thanks for your attention.
Thank you, Dr. Basu. Dr. Basu is the president of our association, and he has busted this myth that, after every spine surgery, patient will never be able to walk for life. I now invite the next speaker, who is the secretary of our association and the dynamic personality who is behind all these conferences, Dr. Gautam Zaveri, who is also a famous spine surgeon in Mumbai attached to Jaslok Hospital, to now enlighten us how recovery is enhanced after spine surgery. Gautam.
In spite of significant advances in the field of spinal surgery, with minimally invasive surgery, spinal navigation, spinal robotics, the word spine surgery still evokes a lot of anxiety, apprehension, fear, and even tears from both the patients and their relatives. So why is spine surgery so fearful for the patient? Why are patients dissatisfied with the outcomes of spine surgery? The primary reason is that there is a significant mismatch between what the patient expects and what the surgeon is able to deliver. The patient expects that not only should he get a relief of complaints, but it should be with minimum postoperative pain. He should be able to mobilize early postoperatively and return home early, and again return to work as early as possible. Besides this, he also wants absence of complications. The surgeon, on the other hand, is able to offer a technically well-done surgery without guaranteeing that all the other outcomes. And therefore, in order to meet with patient expectations, it is vital to put the patient at the center of our entire operative, perioperative process to improve patient satisfaction. The Enhanced Recovery After Spine Surgery program is a multidisciplinary, multimodal approach to perioperative care of patients with undergoing spine surgery, with the goal of improving the clinical outcome, reducing the complication rate, and hastening patient recovery. This program involves not only the spine team, but the anesthetists, the physicians and intensive care specialists, the rehabilitation people such as the physiotherapists, the pain management specialists, and of course the spine care nursing staff. This program was started for general surgery for colorectal work back in the early 2000s and has been used in the US since about 2015 for patients with spine surgery. At the Jaslok Hospital in Bombay, we started a pathway on all our patients undergoing spinal surgery in order to enhance their recovery. Patients chosen for this enhanced recovery program were patients undergoing 1 or 2 level lumbar discectomies or decompression for spinal stenosis, or 1 or 2 level lumbar spinal fusions. Patients had to be less than 75, relatively fit, with a low body mass index. All patients were admitted a day prior to the surgery. But before the admission process began, there was a process of medical optimization and education. Patients' comorbidities were identified, investigated, and appropriate referral was made to a physician, who then optimized the patient as far as these comorbidities was concerned. Nutritional assessment and supplementation was provided. Patient was advised to stop smoking and limit alcohol consumption prior to elective surgery. And at the same time, surgical information was disbursed and counseling was provided. The patient was admitted a day prior to the surgery when again the assessment was performed, this time primarily by the anesthetist and if needed by the physicians too. Patients were taught exercises of the breathing and lower limb exercises. The physiotherapist also taught them transfer from bed to chair. Patients' fasting was limited to about 4 hours prior to the surgery, but clear fluids were allowed even up to 2 hours prior to the surgery. Intraoperatively, all measures were taken to limit the perioperative morbidity. The patient was asked to pass urine before entering the OT. Also, the patient was kept a little under-infused so that the patient did not feel the need to pass urine immediately post-surgery. In this way, indwelling catheters were avoided. Antibiotic prophylaxis was administered to reduce the risk of surgical site infection. Antiemetic prophylaxis reduced the risk of postoperative nausea and vomiting. DVT prophylaxis was provided, and patient was given adequate multimodal analgesia to reduce the postoperative pain. Surgery was performed using less invasive techniques to limit the surgical morbidity. This included smaller incisions, little muscle dissection, limited excision of bone and ligaments, and meticulous hemostasis. The patient's skin and muscle were infiltrated with sensorcaine, and periradicular infiltration was done with steroids and sensorcaine to provide perioperative analgesia. In the postoperative period, good pain control was absolutely vital because it ensured patient comfort and allowed the patient to participate in early mobilization. Adequate analgesia was provided, giving a combination of diclofenac and paracetamol. Tramadol was avoided as far as possible unless the patient had severe pain. We also used buprenorphine patches to control the pain. Oral intakes were started between 4 to 6 hours after surgery. Breathing, lower limb exercises were encouraged, and patient was encouraged to get out of bed within 4 to 6 hours after the surgery. He was encouraged to go to the washroom and void urine the same evening. Isabgol powder and cremophene syrup were administered to help bowel movement. Drain was removed after 48 hours and a dressing was done. Discharge was planned when there was adequate pain control with oral medications, patient was able to climb a flight of stairs, had a bowel movement, and there was no perioperative complication. After discharge, the patient was advised to remove the dressing at home after 12 days since the sutures were subcuticular. Progressive increase in activities of daily living was advised. A phone call was made 2 days and 1 week after discharge by the spine fellow to check status of recovery, and an emergency number was provided to the patient in case of any uncertainties. By employing this kind of an enhanced recovery program, we found that our hospital stay for patients undergoing lumbar microdiscectomy reduced from 5.3 to 2.9 days. Patients were mobilized on the same day after about 4 hours following the surgery, and they had excellent pain control. The patient satisfaction score was extremely high. Even in elderly patients who underwent decompression for single or multi-level lumbar canal stenosis, the hospital stay was reduced from 7.2 to 3.3 days. The patients were mobilized out of bed, again the same evening within 4 hours, and the patient satisfactory score was very good. Lumbar fusion surgery, which is a much larger surgery involving more muscle dissection and more blood loss, even in these patients, the hospital stay was significantly reduced and patients were extremely satisfied with the outcomes of surgery. Similarly, we tried the program for our cervical spine, anterior cervical decompressions and fusions, and posterior cervical laminectomies. Most patients were mobilized on the day of surgery itself and discharged within 48 hours. To conclude, modern healthcare is all about delivering what the patient expects and patient wants out of the surgery. It is time for modern healthcare to focus on this, and the ERAS programs gives us an idea of how to go ahead in improving in meeting with patient expectations and improving outcomes. In our hospital, the ERAS program has resulted in a reduced perioperative complication rate. It enables faster mobilization, shortens the hospital stay, allows earlier return to activity daily living, and improved the patient satisfaction scores. Thank you very much.
Thanks, Gautam. A lot of patients feel that after spine surgery, you will be on the bed for a month or two. Dr. Zaveri has clearly told us that how this enhanced program, post-operative care, has changed the way patients perceive post-operative care in spine surgery. I request Dr. Bansure to invite our next speaker now.
Our next speaker will be speaking on minimally invasive surgery. I invite him to speak.
Hello everybody. So today in ASICON 2021 in the virtual meet we talk about the minimally invasive spine surgery. Now what is minimally invasive spine surgery? Like in any field, the importance is getting towards a minimal invasive approach to achieve the surgical goals. So is this a technology or this is a technique or it is a marketing ploy? There's all a mixture there. There is a philosophy involved in it. And this is for the benefit of the patient to minimize the collateral damage, to preserve as much as normal anatomy of the patient, and to reduce the overall stress to the patient. All the while, you have to achieve the goals of an open surgery. Minimal invasive surgery has got multiple aspects, and one of them is a spine endoscopy. And would you believe it or not, this is a patient of operated already open surgery, and the first experience of him was a 2 months to 3 months bed rest. Though he was quite okay after the open surgery and had got a 4 years good outcome, he developed a new disc prolapse at L23 level. The old operated level was L45, and this is his MRI. And I did an endoscopic surgery in this patient. This is the post-operative MRI on the same day, and the patient is discharged the same day. This is where the endoscope is positioned. It was under local anesthesia, and this is his dressing. So this is a win situation for patient and me. So for any surgery, what you have to do, the basic necessities is light, good magnification and vision, and instruments. For a routine surgery, like a posterior surgery of the back, lower back, in spine, we give the patient a position in the prone position and usually give an incision on the back. This is how we position. So I'll give an example to make it more palatable as to what is minimally invasive spine surgery. And this surgery is being done with a midline incision in the middle, and this is the operating surgeon. We had something mounted on his head which throws light specifically where it is needed, and at the same time the lens which is there which gives him good magnification to clearly see. At the same time you can see the assistant who can assist him in operation and see everything also clearly. So it is a further addition to what you can see by naked eyes, but you can see the field. There is a lot of cutting there, there is blood in the field. At the same time you can use a microscope there. By doing a microscopic surgery, what you do is the incision becomes smaller. The assistant as well as the surgeon both are looking through an instrument which is the microscope. So there is lesser amount of cutting of the normal tissues to reach to the target place where you have to do your job of decompressing or achieving your surgical goals. At the same time, if you are using a tubular retractor along with microscope, this becomes tubular assisted microscopic surgeries. So these are tube surgeries. So microscopes can be loops which are mounted on your head, and at the same time it can be on a big stand, and they are more technologically evolved and bigger, and they are specifically used when you are doing actual surgeries of the spinal cord itself. You are cutting the spinal cord, then you may need the microscope like instruments. These are exoscopes outside the body. At the same time, endoscope is a pen-like thin instrument which has got both light, magnification, and the working channels inside it inbuilt. So that's how the microscope and the endoscope are differentiated. The open surgeries would have a midline incisions of 1.5 to 2 inch for achieving something like a laminectomy surgery and decompression. At the same time, a microscope assisted surgery, this incision would get reduced to 1 inch to 1.5 inch. And at the same time, a microscope with a tubular surgery may get reduced to a size of say 16 to 40 mm depending upon the condition to be addressed. So this is technological evolution. And at the same time, endoscope is something wherein the cutting is just a band-aid dressing. So you have a 7 to 10 mm cut you have. So this is all a bit confusing. The advantage of this is the MIS surgeries is the incision size is very less. There is negligible amount of blood loss which is there. It can be done under local anesthesia and regional anesthesia, so the patient discharge gets very fast with early healing, and targeted work is done without anatomical structural damage to the whole of the part which we are addressing. Immediately the patient get mobilized. Usually in some cases it may be 1 day surgery or a few day surgery, and the faster resumption of the duties is there because of less pain, because of healing, and for same reason it is more cosmetic also. But is everything only green or good? Is it 100% successful? Here is where is the caveat to be learned in minimally invasive spine surgery. Failures are a big part of minimally invasive spine surgeries. 5 to 40% of the total failures of the operated cases. In fact, you may not get any relief in these cases. Why did this happen? This happens because the surgeon has done a minimally invasive surgery in a case of an indication wherein it is possible only by open. So the achievable target is not achieved. So that becomes a wrong indication and there is a failure there. At the same time, the training is very much important for the surgeon. At the same time, the experience is very much important for the surgeon, because an open surgery you can achieve the skills needed in few years itself, and for an endoscopic surgery or say minimally invasive surgeries you may require say half decade to a full decade also. So at the same time, what you are seeing in the practice is that there are so many number of people like pain physicians who end up doing endoscopic surgeries. So they are not trained to do, and that can create even more problems and many failures. So this is a common thing which we are seeing there. The other thing, what is negativity I have taught the minimally invasive surgery is the cost, because every technology and technique comes at a cost. You cannot get a Mercedes at a cost of a Maruti. So it's not possible. Screws and plates may be needed in many of the unstable situations of the spine surgeries, and in that case you cannot go by the way of an endoscopic surgery. Yes, screws can be put in the minimally invasive way, and it is needed in many of the cases whenever instability is there. So now coming to the final question, which doctor to choose? Because you know about all these things. It's like a hypermarket. You have so much things, but which to choose? So here is the thing. You have to surrender to your doctor. You have to understand all these things from your doctor as to what is the type of surgery which is best in his case, and follow whatever your doctor is saying. Don't try to insist that do a minimal invasive spine surgery or a endoscopic surgery in your case, which probably may need an open surgery only. So this is very much important, because your unnecessary pressure may make a junior surgeon to commit to you an endoscopic surgery or a MIS surgery, and that is one of the biggest reasons for those many failures which I just talked about. You may be aware that there had been a time when bypass surgery was the only outcome for blocked channels to the cardiac vessels. At the same time, by the arrival of the angioplasty, the number of cardiac surgery just drastically reduced to nearly 70%. So angioplasty still works in single block vessels and many of the other indications which I am not an expert. But at the same time, bypass still remains there. So these are all a spectrum of things which you have to understand. Endoscopy or minimally invasive surgeries cannot work in all cases. At the same time, it is time tested open surgery which will work in most of the cases. Yes, technology will evolve and slowly many of the diseases can be handled by a minimally invasive spine surgery. So the basic need with minimally invasive spine surgery is lights, magnification and instruments, and you have to achieve the surgical goal as equivalent to an open surgery. Thank you very much.
Thank you, Dr. Ajay. With technology, there has been a rapid change in which spine surgery is now being performed. And Dr. Ajay has told us all the pros and cons of minimally invasive spine surgery. Now I invite the last speaker of this seminar, Dr. Vijay Kamat, who is a young, dynamic spine surgeon from Bangalore. He is going to talk about new techniques in spine surgery. There are a lot of things which are coming in spine surgery, and I invite Ajay to enlighten us on that. Ajay.
Good morning, everyone. At the outset, I'd like to thank the ASSI and the IMA for organizing joint session and having me be part of it. My topic is on newer technologies in spine surgery. The previous speakers have already touched upon some aspects of advancements in spine care, and hence there may be a little bit of a repetition. Now, spine surgery has improved leaps and bounds over the last couple of decades. This has happened due to the improvements not only in medical expertise, but also in other branches of science like metallurgy, manufacturing technology, computer hard and software. Instruments and implants are more refined and have improved the ease of doing surgery with improved safety for patients. As far as implants go, we have come a long way from the Harrington rod, which was used to partially correct deformities, to the sublaminar wires in the hard shell rectangle, to the pedicle screws that are available now. This has now allowed the surgeon to perform surgeries that were once considered rather impossible. Like, for example, this girl with a severe kyphotic deformity and paraplegia went on to have a surgery and have partial recovery of her neurological deficits. Pedicle screws continue to evolve and allow for injections of cement through them, which improves the hold in osteoporotic bone, allowing for surgeries to be performed in the elderly population. As can be seen here, these are fenestrated screws, cement injected, and this is what the ball of cement around the screw would look like, as what you're seeing in this image. And these are surgeries which were very difficult once upon a time because the implants didn't hold an osteoporotic bone. Now, implants have improved to such an extent that they allow for spinal surgery to be performed in the pediatric population as well, as in this 21-year-old Mokuyo's child who had a progressive paraplegia. Improvements in cages have also allowed for interbody fusions and reconstructions in patients who had large defects due to tumors, infections, and also due to trauma. And this has helped improve the outcomes and deformity corrections for patients. Now, preserving the growth and function of the spine is a desirable outcome of surgery. As an alternate to fusion surgery, disc replacement can be performed in indicated cases. Now, routinely for a degenerative disc disease, a fusion would be advised, but here you can see a disc replacement has been done, and this allows for preservation of movement and also prevents the development of what is called adjacent segment degeneration. Now, disc replacement is more commonly performed in the lumbar spine as in the cervical spine as compared to the lumbar spine with pretty good predictable outcomes. Correction of spinal deformities in early onset scoliosis, that is in children younger than 8 years in the past, usually warranted fusion of the spine. Now, fusion often resulted in stunted growth and a short spine, which is not a desirable outcome. The use of growth-friendly spinal instrumentation options for early onset scoliosis include growing rods, which are the traditional and the magnetic growth rods. And this is allowed for deformity correction, while at the same time allowing for growth of the spine. Now, this is a case where traditional growth rods are used. You can see these rods have been put in with a connector here. And regularly at 4 to 6 months, a small incision is made here. The spine distraction is done, and the child is then called back 6 months later for a further distraction till the end of this growth spurt. So it allows for maintaining the deformity correction as well as allows for growth of the spine to happen. Okay, magnetically controlled growing rods are a revolutionary change in the management of early onset scoliosis. The rods have a magnetically driven lengthening mechanism where distraction is performed using an external remote controller as seen here, without the need for repeated surgical distractions. This can be performed as an outpatient procedure. Okay, and as can be seen in this picture here, you can see this is when the rods were initially put in, and this is after distraction has happened. And this has made it really good for patients with early onset scoliosis, and they can avoid repeated surgeries. This is a typical case where, with early onset scoliosis, where magnetic growth rods were put in, the deformity was corrected, and when the patient reached her skeletal maturity, she went in for a final fusion using traditional pedicle screws and rods with an excellent result, and also maintaining her growth. Improved instrumentation has allowed for the development of minimally invasive surgery, which has become a boon for patients with outcomes similar to open surgery. What initially required large surgical incisions can now be done through small incisions, reducing the muscle damage and allowing for early recovery for the patient. Now, as can be seen here, while this is the traditional surgery that used to be done, minimally microscopic discectomy through about a 1 or 2.5 centimeter incision, it then came the tubular and endoscopic surgery, which was done through about a 18 mm to 20 mm incision. And now that has been further reduced using full endoscopic surgery to about 8 mm to 1 centimeter. Fully endoscopic surgery is a rapidly advancing area of spine surgery. In fact, with endoscopic discectomy, discectomy and decompression, surgery is performed almost as an outpatient procedure. You can see these advanced endoscopes over here, which allow us to do these complicated procedures through a very minimal incision. Endoscopic surgery is now being expanded to the cervical spine as well, with predictable, good, reliable results. Now, fusion surgeries can also be performed through using these minimally invasive techniques. Special retractors and instruments allow for the fusion of, say, spondylolisthesis or degenerative disc disease through these small retractors over here. And this is the incision that can be seen for a patient who has undergone the single level fusion. Okay, often patients undergoing single or two level fusions are discharged in the first postoperative day. Now, even multiple level surgeries can be performed using minimally invasive surgeries, as in this patient who had multi-level trauma. You can see the small little incisions on his back. Now, image-guided surgery has really revolutionized spine surgery. Now, computer-navigated image-guided surgery has helped to improve the accuracy of implant positioning and hence the safety of the procedure. And this has been documented in multiple studies to be in the range of about 95 to 98%. It also reduces the radiation exposure to the patient and the surgeon. The system works pretty similar to GPS that we use on our phones. The computer gives the patient and the surgeon real-time multiplanar images, as can be seen over here. And using tracked instruments, the implants are placed safely. Now, this is just a short video for you to see where the initial hole is being made for the screw to put in. Then a tract is being made for using these special instruments to place the screw in. And finally, a screw is then put in. And this can all be done minimally invasively using computer-navigated surgery. Robotics have added a new dimension to spinal surgery, and it further enhances the safety. This is basically an amalgamation of image-guided surgery with a robotic arm to help guide and stabilize the instruments. Now, when performing complex spinal surgeries, for example, this tumor resection, which is the two-level vertebrectomy, the biggest worry for the patient and the surgeon is spinal cord injury. Intraoperative neuromonitoring is a technology that is used to alert the surgeon if spinal cord injury is occurring and hence improve the safety of spinal surgery. Two signals are monitored. One is called the SSEPs, which monitors your posterior columns, and the MEPs, which monitors your motor tracts. Okay, the patient is hooked up to the machine, and this is what a normal recording would look like. Any deviation alerts the surgeon that the spinal cord integrity is being compromised, and he can either reverse or prevent or stop whatever part of the procedure he's doing. And this has really helped to allow us to do really complex surgeries with minimal morbidity and neurological deficit to the patient. The prevalence of osteoporosis and its consequences, that is fragility fractures, is increasing worldwide in parallel with the global aging population. Vertebral fractures leads to pain, deformity, and also cardiopulmonary compromise. Treatments of these fractures were once considered difficult as the weak bone would not hold on to implants. A significant change occurred with the introduction of the use of bone cement. Vertebroplasty was a procedure in which a cannula is inserted into the bone percutaneously, and then the fracture cavity was filled up with bone cement. And this stabilized the fracture, providing pain relief and also preventing further deformity. Refinement in the procedure came with the improvement in technology, leading to the procedure of kyphoplasty. A balloon, as can be seen here, is inserted into the bone percutaneously and it's inflated. So this reduces the kyphotic deformity, and the cavity then formed is filled with bone cement, giving better results compared to vertebroplasty. Bone cement can also be used to fill voids in pathological fractures. For example, in this case of a C2 tumor here, which is stabilized posteriorly and the void in front filled up with bone cement, giving immediate stability. Now, we have to understand that while we as surgeons can do major surgeries, we need a team to support us. To perform complex surgeries, you need a good anesthetic team. Improvements have occurred in anesthetic medications as well as their skill, and this allows for hypotensive anesthesia to reduce the bleeding in our operative field, and also to anesthetize the patient without muscle relaxants to allow us to use intraoperative neuromonitoring and hence perform our surgery safely. Improvements in anesthesia have made it possible for surgeons to perform complex surgeries in a very safe environment. Also, while doing major surgeries, bleeding can be a significant problem. Improvements in transfusion technology, mainly autologous transfusion, where the patient is bled a few weeks in advance and blood transfusions done when required, reduces the disadvantages of allogenic transfusion. Improved and newer hemostatic agents, as can be seen here, have also helped us to control bleeding. But one of the most significant improvements has been the use of cell saver technology. Simply put, the surgical field is sucked out into the machine. The blood in the surgical field is sucked out into a machine that removes the unwanted debris and saves the RBCs, which can then be transfused back into the patient immediately, hence saving valuable blood. So as can be seen, there have been numerous advancements in spine surgery, mainly in instrumentation implants, which has helped us to improve our deformity corrections, allowed us to do minimally invasive surgeries, which have vastly benefited the patients, both in terms of pain as well as getting back to work early. Navigation and robotic surgeries have allowed us to place these implants in a safe manner. Intraoperative neuromonitoring has helped to guide the surgeon so that we do not cause neurological injury to the patient. And the use of bone cement has really helped us in osteoporotic bones. Of course, all this has been complemented by improvements in anesthesia and blood transfusion technology. Once again, thank you for your patient hearing.
Thank you, Dr. Vijay. That was an excellent talk on technology. We'll have a brief discussion before we wind up this session. There is one question from Dr. Kulkarni to Dr. Jaiswal. Dr. Kulkarni has asked that in his practice, he sees a lot of patients who complain of two specific points of pain. One is this spot around trapezius and one around the medial border of scapula. So what sort of exercises, and all this pain increases with stress. So how do you counsel them? What investigations you do and what sort of exercises you tell them?
First of all, we have to examine the patient in detail, whether it is a cervical radiculopathy. Usually a C7 radiculopathy radiates to the medial border of the scapula. Okay, if it confirms clinically it's a radiculopathy, then we have to move accordingly. Okay, and most of these patients of vague pain coming from the neck and upper back is work related. IT people working on the computer for long hours can have this type of pain. Preferably, these patients should be put on a neck exercises, that is stretching and straining exercises and upper back exercises.
Thank you, Dr. Jaiswal. There is one question from Dr. Raut from Sangli. This question is to Ajay Krishnan. Dr. Raut says that patient sees a senior surgeon and he tells them that he needs a laminectomy for stenosis and the budget is 30,000 rupees. And then he goes to a urban city, Pune, and then he comes back and he tells them now the budget has become 1 lakh. It's an endoscopic surgery. Doctor, what should I do? How should I counsel these patients? Ajay, can you please answer Dr. Raut?
Now this is always going to be the dilemma in our setup where things are not insurance driven and things are not covered under the health policies. So what happens is that it is the surgeon who is spending from his pocket for his training, usually had made out huge investments for procuring these instruments, and they come at a very big cost. So those who have put in number of years for them, they will definitely make a higher charge. And there is nothing wrong in that also, because you can see in every practice this is there may be an affidavit which is made in 100 rupees also, also, and for an affidavit 10 lakh rupees may be charged also. So that is the branding of the surgeon who has built it. So you have to counsel the patient and guide them towards places where a cheaper surgery of endoscopy can be done if it is feasible. See, the thing is that if it is feasible to be done by a minimally invasive approach, always a minimally invasive approach should be taken. But you trying to get that surgery at a smaller cost, that is not appealing also, and you won't get the outcome also.
Yeah, Dr. Raut wants to know, is there any long-term difference if they go for a traditional surgery?
No. Everything has got its own advantages. Now, minimal access definitely preserves your anatomy, definitely preserves the structural and functional aspect of your spine. Definitive evidences are there. Long-term outcomes for the functionality of that part of the body is more. But at the same time, you have to remember that spine is a complex joint which is at one segment itself having three parts, say disc and two facet joints. So continuous degeneration is going to occur. So for an minimally invasive surgery or an open surgery, you are still going to get something at a degenerative other level also. And these things are considered as failures by the patient themselves. It's not so. It is the disease, the degeneration which is progressing.
Right. A question from Dr. Mehta from Rajkot to Dr. Basu. Dr. Mehta says that after seeing a spine surgeon, my patient was advised surgery. I counseled him to undergo the surgery, but unfortunately, this patient had a neurological problem post-operative, is not able to walk. The family comes back to me blaming me. Now, how should I deal with this situation? Dr.
Right.
Basu.
Thanks for the question. I think this is a very, very pertinent problem in our society, that as the family physicians are the first point of contact, and in many a times when the family physicians refer a patient to a particular surgeon or a hospital and there is some sort of a major adverse event, the family physician has to bear the brunt of the blame game. Now, first, it is important to realize that spine surgery is a huge spectrum. Only at one end of the spectrum is a possible paralysis. Now, once the paralysis has occurred, the first and foremost thing which should be done is to reassure them that most of the paralysis which happens, or most of the major neurological deficit which happens immediately after spine surgery, usually recovers to a major extent over the next 6 to 9 months. And continuous reassessment, rehabilitation, physiotherapy, and reassurance should be done to these patients. Second is that before getting into a spine surgery, all patients should understand that accidents do and can happen. For example, if you're going out of a house, if you're traveling to a leisure destination, you can suffer an accident. So accident is something which everybody has to take into account. That is something which we cannot predict or have anything about. But you have to look at the huge amount of spine surgery which is going across without any complication. So this sort of understanding and reassurance is the most important thing.
Thank you, Dr. Basu. There's a note from Dr. Singh from Amritsar to Dr. Gautam. He has congratulated him for a year, and he is saying that most of my post-op patients are on a lot of analgesics for a long time, especially pregabalin. How safe is this, and why they should be on analgesics for such a long time even after having surgery?
So that's a very good question, sir. I don't see any reason why patients should be on long-term analgesics after surgery. Typically, in our practice, we give analgesics for a week or so. After a simple discectomy, we give analgesics for a week or so. Let me start by saying that you should give analgesics because you want to relieve the patient's immediate postoperative pain. If the patient has less postoperative pain, his mental comfort is better and he's able to cooperate with the exercises, etc., much better. So giving good relief of pain is vital in the perioperative period. But most of the patients within 72 hours are fairly comfortable. And then you can scale down the analgesia significantly so that within a week or 10 days, most of the analgesics are gone, and then you are giving them very little, maybe paracetamol or even a simple Ultracet to relieve the pain, if at all. Gabapentin I do not use in my practice. I do not like that drug. Gabapentin is purely an analgesic. It is a central analgesic. It has no anti-inflammatory effect. Most of your postoperative pain comes from inflammation, which causes secondary muscle spasm. So if you're going to give gabapentin, you have to give it along with anti-inflammatory drugs in order to control the pain. And that way you reduce the side effects of both the drugs. Gabapentin additionally has a lot of side effects. Not a lot of people, especially elderly people and ladies, cannot tolerate it. It causes giddiness, nausea, vomiting, headache, sleep disturbances. And generally they keep on calling you about these problems, and therefore I avoid it in my practice.
Thank you, Dr. Gautam. Dr. Bhattacharya from Orissa has asked Dr. Vijay that will biologicals take over surgery? Will it be the end of spine surgery in future? Dr. Vijay.
Yeah, I think, can you hear me?
Yes.
Yeah, I think biologicals is very early. It's really in its infancy right now. The first thing obviously is to have a very clear understanding of the pathology. Like, for example, I mean, the most common pathology being disc degeneration. We are still in the process of trying to find out what initiates disc degeneration and, you know, what can be done from there on. So I think the first step will be there. And then once we've understood the etiology, then biologicals to, you know, tackle those. But I'm sure, you know, it's just a matter of time before which biological therapies will, at least to a certain extent, take over, I mean, reduce some part of the spine surgery. But there are going to be things like spinal deformities and instabilities where, you know, biologicals will not be able to, you know, manage the problems. And so I think it's not that spine surgery is going to be wiped off the field, but yes, maybe, you know, the requirements may come down.
Thank you, Dr. Vijay. Dr. Bansode, you want to ask any questions to our panelists? To wind up this seminar, which has been an excellent exposition to all the family practitioners. Thank you.
Thank you very much, Dr. Amol, Dr. Bansode, Dr. Pragnesh Shah for moderating this session. And we now, as we come to the end of the day, I think we have got a lot of questions from the delegates over here who have been attentively listening to the questions, and I'm getting WhatsApp messages here saying that how the program has been so lucid, so clear, and so helpful to all of them. I thank all of you for watching the show. But before we end, I have a formality to do. I have to request the Secretary of the Association of Spinal Surgeons of India to give us a vote of thanks. Our secretary is Dr. Ajay Shetty, who is a very senior spine surgeon from the Ganga Hospital in Coimbatore. We also have with us our future president, who is taking over as a president from the end of this week, and that is Dr. Shankaracharya from the Gangaram Hospital in Delhi. I would request Dr. Shankaracharya to say a couple of words, and then Dr. Ajay Shetty to wind the session for the day. Thank you. Dr. Shankar. I don't think I think he might have just stepped out for lunch. Dr. Ajay, please, can you conclude the session?
Thank you, Gautam. At the outset, sincere thanks to the presidents of various organizations, Dr. Chabra, president of ASSI, Dr. Jayalal, the president of IMA, and Dr. Jayesh Lile, the Honorary Secretary General of the IMA, Dr. Abhay Dikshit, the president of FFPA, and Dr. Bharat Bhatt, the president of the GPA Greater Mumbai. I'm sure this masterclass in spinal surgery for family physician has been very useful to all of us who are here. It has been interactive. There are a lot of aspects of general spinal care which have been discussed in detail. The talks, as mentioned by Gautam, has been very lucid. And I'm sure that it will give us an opportunity for us to have these sorts of programs in the future, maybe once in 3 months or so, wherein a combination of general physicians and spine surgeons could interact and so that there is a better understanding of spinal problems among all of us. I would like to thank all the faculty members who are present here today and who have taken their time off from their busy schedule, especially on a Sunday, to be here with us and to deliver their lectures. A sincere thanks to all the people who have registered and have attended the sessions. Before I conclude, I would like to thank the major sponsor for today's session, Mr. Swaroop Singh from Inta Sakila. I thank you all for being here with us, and I hope that we will have further future interactions with the general physicians in the year to come. Thank you all.
Thank you, Ajay. And with that, as we come to a close, let me assure the family physicians who have come here that we, as Association of Spinal Surgeons of India, would love to get associated with all of you. We definitely believe that 80% of patients who come to our practice should be treated by the family physicians before they come to us. That way, there will be a better triaging of patients, and we want to work hand in hand with all of you to provide care to our communities. And to help us provide this care, Intas Akila has helped us sponsor this program, and they are going to get a CD made of the entire recording of this program, and hopefully they will be circulating it to you over the next month or so. So thank you very much, ASSI President Dr. Chabra, ASSI Secretary Dr. Ajay Shetty, and two future presidents, Dr. Shankaracharya and Dr. Saumyajit Basu, who have been with us today. I thank each and every one of my faculty members, including the presidents of all the various societies, that is Dr. Jayalal, Dr. Abhay Dikshit, Dr. Bharat Bhatt, the secretaries, and of course, Dr. Janak Shah, who helped coordinate the whole thing, and Dr. Jayesh Lele from the Honorary Secretary General of IMA. With that, on behalf of the ASSI, I bring this meeting to a close. Good day.
Good day. Thank you, Gautam.